Okay.
So we should be recording at this point.
Great. Thanks, Patrick.
I think we're good to go. Thank you, Kimber.
Okay, so we just like to start out by putting this slide up at the beginning, just to remind everybody that this presentation is recorded and we make it available through our website for people who don't have this time slot free. So I also like to start out by thanking our co-sponsors, who are the Global Public Health minor, the School of Public and Community Health Sciences, and then our Bridge Institute between the university campus and the hospital campuses in town, the Institute of Health and Humanities. So this week, I'm excited to introduce two of my colleagues and old friends, really, from the Adara Development group that I've worked with since the late 1990s, Heidi Nakamura and Brooke Magnusson. So I'll tell you a little bit about them. Heidi brings 33 years of clinical experience in the neonatal intensive care units where she's worked, and she's held various roles over the course of her career and joined Adara as the Director of Global Health in 2017. So one of Adara's cornerstone projects has been the development of a NICU in partnership with Chuoko Hospital in central Uganda. And today that NICU cares for over 1,200 babies per year, and it's recognized as a center of excellence in newborn care within Uganda. And she is joined by Brooke Magnusson. Brooke brings over 17 years of public health project management and research experience to the Adara team. And she's worked in the nonprofit, government, and private sectors with a passion for bringing diverse groups together for a common goal. So she works across Adara's maternal, newborn, and child health programs to develop and strengthen global health partnerships, including partnerships with PATH, University of Washington, Seattle Children's Hospital, the London School of Hygiene and Tropical Medicine, and Adara Development even has 2 interns here in our program in the School of Public and Community Health Sciences, who are working with me in innovation and best practice, which are areas I help Adara with as a senior advisor. So just a shout out to our 2 of our students in our grad program, Kim Cancer and Chelsea Kuiper. And so Brooke and Heidi are joining us today to talk about one of the programs they currently implement. It's called the Hospital to Home program. It is funded via Grand Challenges Canada's Saving Brains initiative, which is a public-private partnership effort bringing together funds from Gates, World Vision, the bank UBS, and a couple of others in an effort to address the fact that 1 in 3 children, that's 200 million globally annually, fail to reach their full physical, cognitive, psychological, and/or socio-emotional potential due to poverty, poor health and nutrition, insufficient care and stimulation, and other risk factors in early childhood development. So Brooke and Heidi are working on this program, Hospital to Home, which really focuses on this area. And I'm going to turn it over to you now, Brooke and Heidi, and let you take it away. Thank you.
Thanks, Kimber. And I'm going to go ahead and share my screen. Can everybody see that okay? Okay, great.
It looks good.
So thanks for the intro. Heidi and I are very happy to be here today, and thanks to Kimber for the invitation. And as Kimber said, we're going to talk a lot about the Hospital to Home program. We're also going to give you a little background about Adara and kind of touch on some other points as well. So we both have the privilege and the joy of working for Adara Development, where together we believe in the vision that each and every person deserves access to quality health, education, and other essential services, no matter where they live. So how do we do this? Well, we have a pretty unique model that supports all of the work that we do. And we see Adara as a bridge, and this is bringing together the world of business together with the world of people in extreme poverty. And we have some brilliant and generous finance experts in Australia, which is where the administrative core of Adara sits. And these experts give their time and their expertise pro bono, and they provide business consultation on behalf of Adara. And so we call this group Adara Partners. The fees that they generate are donated entirely to fund the overhead costs for Adara Development. In 2019, this was over $1.3 million. And so by paying for our overhead costs, this means that all of the donations and the grants that Adara receives can go entirely to the direct project costs, which is pretty incredible. We hope that eventually this model can grow into other markets like New York or London. And ideally, different sectors would have the same concept of a panel that uses their expertise to generate funds. And then those funds would then go to support worthy causes. And so that wouldn't just be for Adara, but other NGOs. And so we think that there's a lot of promise in this model. The work that Adara Development does is mostly in two areas: remote community development and maternal newborn child health. And so when Odette, the smiling woman in pink in the corner, when she originally founded the organization, she wanted to work in places with the greatest need, and in landlocked, remote, and rural places where others thought it might be too difficult to go. And so one of these places was Humla, Nepal. And as many of you probably know, Dr. McKay has been working alongside Adara's Nepali colleagues in this region for over 20 years. And Dr. McKay and Odette had a very fortuitous meeting in Nepal, and we're really grateful that they did, because that's brought us here today. So a lot of Adara's work in Nepal revolves around education and then also around health. And this picture shows just how remote this area really is. It's incredibly beautiful. And Dr. McKay is probably more than happy to answer any questions that you might have about the work we do there. And while Heidi and I aren't going to talk about Adara programs in that particular region, it represents a whole body of work that Adara does. And the other piece of our work really revolves around maternal newborn child health. And this work is mostly centered in Uganda, and that's what we'll be sharing today. So let's imagine that we are all getting vaccinated and it's safer to travel. So we can put on our masks and our face shields and we get on a plane and we take a 16-hour flight to Dubai. We slip at the airport. We take another 6-hour flight to Uganda and we start driving down some dusty roads for several hours, and we arrive in the region of Nakaseki. This is in central Uganda. The paved roads end and you'll see the red dirt road here begins. Cars become fewer. We see more people on bicycles, more people walking, and we see kids like this fetching water from the local borehole. And it's in this region where we find Ruth. And this is Ruth in her home. You can see her in there. It's kind of tough to see her face, but she's in there. And Ruth is pregnant. She goes into labor, but she knows that her baby is early and she knows that she needs help. The nearest health facility is about 2 hours away on foot, and she does not have any money to hire a motorcycle to carry her. So she leaves her home and she begins walking in labor down that road that you just saw. And she arrives at a health facility that looks something like this. And there's very few supplies. There's only one healthcare provider. And she delivers her baby 2 months early, just under 4 pounds. And her baby is very sick and her baby is small. And because there are so few healthcare workers who know how to care for these premature babies, her baby sadly becomes a statistic. And her story is very common. And to help us compare the problem to other countries, in this slide, the size of the empty crib represents the mortality ratio in 3 countries. So this first one is Iceland. This is the United States, and this is Uganda. And in Uganda, over 100 babies die every day. It's every single day. And that's about 3 times as many COVID deaths per day as we have in Washington state right now. Uganda is a little bit bigger than Washington, geographically speaking, and it's smaller than Montana. I think it's about 2/3 the size of Montana. And the most distressing part is that almost all of these deaths in Uganda are preventable with simple interventions. So what is it that we do? As Kimber mentioned, Adara has partnered with Chwoko Hospital. And this is a not-for-profit hospital that was at the heart of the location of Uganda's civil war back in the 80s. And when the partnership between Adara and Chwoko began in the 90s, there were no neonatologists in the country. There were very few people doing newborn care, and we heard from the community that their babies were dying. So slowly, we worked with Chwoko to help them introduce health programs. We started in the community and eventually helped them to develop a newborn care unit or neonatal intensive care unit or NICU. And here's a picture of the NICU in the early days in 2004 and then more recently. So at the beginning, medical volunteers would travel from the United States to Uganda, and Heidi was one of these, and so she'll explain a little bit more about what that experience was like in the beginning. And these volunteers would spend several weeks at a time working side by side their colleagues, their Ugandan colleagues, to share knowledge. And at the time, none of that expertise was available within the country. So in addition, hospitals in Seattle would donate supplies that were unused, but otherwise they would be thrown out. And Adara would pack them into a really large shipping container and then send them to the hospital. And hospitals also donated equipment that would otherwise be thrown out. But just something to note around the equipment is that the types of equipment that would work in a Montana or a Washington NICU are not always designed to withstand the heat and the dust or 24/7 use that they might have in a setting like Chuoko. And they often don't work well with the electrical systems in the setting where they're donated. And sometimes those pieces of equipment arrive without spare parts or without manuals. And sometimes they're at the end of their lifespan. And so when they break without those extra parts that can't be sourced locally, they can't be repaired. And so almost every hospital in Uganda, at least the ones that I've been to, has an equipment graveyard. And this is where the equipment sits, usually unused. And in the early days, a lot of the equipment and supplies for newborns just weren't available locally. And so those donated pieces of equipment were really the only option. But with time, a lot of that equipment is now available in Africa. And so we always source these types of equipment and supplies locally whenever we can. So now I'm going to hand it over to Heidi to share a little bit about what it was like working in Chuoko in the early days.
Thanks, Brooke. The early days in the NICU at Chuoko were difficult. And because like many of the newborn care units in Uganda today, the staff had limited knowledge and equipment and supplies and even infrastructure. And there are a few oxygen plants within Uganda, so hospitals rely upon a piece of equipment called an oxygen concentrator. And this is a machine that draws in room air and concentrates the oxygen found in that air, and then can turn around and supply a percentage of 90 to 95% oxygen. This is a great system. However, the equipment also requires electricity. And electricity is often unreliable or even non-existent in some places in Uganda. So in the early days, before we had a designated generator for the NICU, babies on oxygen support would sadly die during a power outage. As you might imagine, that working in such conditions, healthcare staff are often demoralized. And I remember this one time when I was in Chuoko as a volunteer nurse, and it was in the early days of the unit. And our fourth baby had just died that day. And I was standing in the middle of the unit. I couldn't move, and I really felt like I was going to cry. And I was just overcome with a feeling of hopelessness. And the staff were carrying on with their work, and I couldn't help but wonder, like, how do they do this day after day? How do they cope? And I came to realize that it wasn't because they didn't care. It was because they had seen death so often that it just became the norm. And they really just didn't know anything different. And I believe that they had to make themselves numb to death in order to survive. So we started to build the NICU slowly over time, and we provided them with the proper tools. So education and skills, enough staff, equipment, supplies, medicine, support. And when we provided these things and we saw care starting to improve, staff discovered that they have the ability to make a difference and to save a life. And with that first very tiny baby that we saved, attitudes start to change. And hope creeps in. And hope is a powerful thing. And there's this realization that they can make a difference and they can save a life. And this results in passionate nurses and doctors just driven and dedicated to do their work. And where before it was too painful to do so because so many babies didn't survive, Now you find them bonding and connecting with the babies and families. I see them fight so hard for each and every life. And Adara is often asked, what is this? And we say it's our secret sauce. And they also ask us, why are the nurses at Chiwoko so special? Because even when you just walk into the NICU, you could sense that there's a difference. And we believe it's passion and hope. And we believe passion is that secret sauce responsible for saving babies' lives. So over time, the unit continued to develop and improve. And here you can see on this chart how survival changed over time in the NICU. The top line shows survival of low birth weight babies, and the bottom line shows survival of very low birth weight babies. And as you can see, the survival of these tiny babies has increased from 30% to 80%. Chiwoko, as Kimber mentioned, now provides the best newborn care in the country and is considered a center of excellence by the Ministry of Health. And other people come to Chiwoko to learn and be inspired what is possible. We've heard stories from teams that come from these other facilities from around the country. And after they visit Chiwoko, they're so inspired by the dedicated and passionate staff and the work that they're doing that they go home themselves and they start newborn units of their own with the support of the ministry, along with mentoring from experienced Adara staff. So the day a baby is ready to be discharged is a joyful day for everybody, staff included. That was my favorite things about working in the NICU, was sending those babies home. It's extremely rewarding to watch a patient you work so hard to save being carried out the door in the arms of a really ecstatic mother. But what happens to these babies after discharge? What happens after they go back home to their village, like Ruth's road, the red dirt road, and back deep into the bush? Chiwoko Hospital offers follow-up care at the hospital and encourages families to bring their babies back to be seen on a regular schedule. But our data shows that compliance for the first return visit was around 31%, and then it quickly fell off to almost nothing after that. So we know there are so many challenges and barriers that would prevent a family from returning to the hospital. And of course, extreme poverty is one of the most significant barriers, but also just the distance they have to travel to get to the hospital. People in Uganda don't own cars, so they pile onto packed buses or more likely on the back of a motorcycle taxi carrying their baby in their arms. And sometimes I can't help but think that that's even more dangerous than coming to the hospital. So if some of you listening today have your own children, I want you to think about your own experience after you had your baby. And you most likely selected a pediatrician before your baby was born. Maybe you even interviewed more than one. And if your baby was high risk, you had a follow-up appointment scheduled even before you left the hospital. Chances are you saw your doctor or talked to your doctor many times in the first month. And if you needed extra help, you'd have access to nurse hotlines, clinics, hospitals, books, or maybe even you consulted with Dr. Google. But for our Ugandan mothers, returning home to their village is much different. They may be hours away from the nearest hospital or any other health facility for that matter. And the local health centers, as Brooke mentioned, if they are available, they usually only have one-room clinics, many of them without electricity. The staff most likely have no training in newborn care. And even if they did, they don't have any of the equipment, medicines that are required to treat them. And there are just very few pediatricians in the country. And the few that there are practicing near the capital city of Kampala. So we really didn't know what happened to our babies. We weren't sure what happened to them after discharge. But we would hear anecdotal stories revealing that some of our babies were dying in the community without the follow-up support that they required. And we knew we needed to do something to improve the outcome for our babies. So here's where our program Hospital at Home comes in. As Kimber mentioned, we applied for a grant to help fund the development of the program because we knew it would take time and money. And gratefully, we received funding from Saving Brains. And Saving Brains is a consortium led by the Canadian government that focuses on the very important protecting and nurturing of early brain development. And the grant has 3 parts: design, implement, and evaluate the program. And designing a program requires deep consultation with your key stakeholders. So we met with our Ugandan staff, and they were deeply involved in project development and design. We held focus groups, and we developed a theory of change. And then we also had discussions with the Ministry of Health to make sure that the program was aligned with their plans and goals for the country. And we met with officials at the district level to make sure that their voices and opinions were also heard. And then we carried out discussions with our local teams to understand the cultural beliefs and values of the community to ensure that our program was relevant. We did a review of the literature to explore what had already been done, so what worked and what didn't work, and to make sure that what we were doing was evidence-based. And essentially what we found was that there hasn't been a whole lot done in this area, and most of the programs were designed for the developed world, so those high-tech, high-functioning NICU units with many resources, but really not much that translated to low and middle income countries. And it took some work to determine how best to adapt these learnings to the very different setting of Uganda. The program needed to be translated respecting the cultural norms and values. And one example that I can think of to illustrate this is related to sudden infant death syndrome, or SIDS. And we wanted to include this as part of parent education. However, concepts of safe sleep contradict cultural norms in Uganda. So the principles of safe sleep include no loose blankets, especially around the baby's face. Care should be taken not to overheat the baby, and a separate sleeping surface is recommended for the mother and the baby. And in Uganda, despite the heat, mothers wrap their babies in layers and layers of heavy blankets and scarves, usually covering their face. And many families sleep on the ground or on a mat with their baby tucked in close beside them. And when we introduced this to the staff, they had never heard of SIDS before. We talked about cultural norms and how this might be a challenge to implement. And our discussion included whether it was culturally appropriate even to include it at all. Initially, the staff felt like it wouldn't work, but later decided, hey, this is really important, and I think change needs to start somewhere. So it's been really interesting to see how this has now become one of the favorite pieces of the program for them, mainly because of the impact they're making, I think. They believe that babies used to die due to suffocation, and that this teaching is really saving lives. And hey, also super amazing that they are actually starting to change those cultural norms. So pretty exciting. It was also important to consider resource considerations. In Uganda, there's a severe shortage of healthcare workforce, leading to staffing limitations. Tight budgets are a reality, and we always have an eye towards scale and the need to keep those costs low. We concentrated on what is truly feasible within such a health system. We ensured that implementation was locally led, hoping to build engagement and ownership of the work. Another really important thing is to find program champions. So these are the passionate and the workers that truly believe in what they're doing. And we're so lucky to have this amazing, fantastic, dedicated staff involved with the hospital home program. I'm just going to introduce you to a few of them. On the left is Tadeo with his huge, beautiful grin. And we like to refer to him as the first neonatal therapist in Uganda, and actually the only neonatal therapist in Uganda. He's super proud of that title, and he's already started to think about how he can mentor others in Uganda in this groundbreaking area. In the middle are Margaret and Joyce, our discharge coordinators, who are 2 amazing nurses who share the role of discharge coordinator in the NICU. And they work closely with the families, educating and supporting the mothers and coordinating the discharge process. And on the right is Corny, or Cornichi, and she's a very experienced midwife and community nurse who provides supportive supervision to the team of community health workers for the H2H program. They're also called VHTs, standing for Village Health Teams. And at the top of the slide are some of our fabulous VHTs after receiving their new bicycles upon the completion of training. So these are our program champions, and I believe are truly the reason why our program has been successful. So a little bit more detail about H2H. We developed a program that focuses on improving outcomes for our babies, not just after discharge, but also in the facility as well. And the in-facility piece focuses on neurodevelopmental care. So protecting the brains of these fragile newborns in this environment that really is often noisy with equipment, painful with the different procedures they receive, and includes the stresses of really just trying to breathe and survive. And we're focusing on decreasing those stresses as much as possible by reducing noise through proper positioning and handling of the baby, safe feeding practices called cue-based feeding, as well as provision of supportive and calming touch for our babies. So research shows that brains of these tiny premature babies may actually develop differently as a result of the added stress in the NICU. Critical motor and sensory pathways of the brain are forming during this time. So looking at the MRI images of brains, which is what you're seeing now, the brains of the premature infant show a brain that is smooth, without those grooves you usually see in the images of adult brains. And it's thought that stress can inhibit the development of these cortical folds or grooves of the brain, and that babies exposed to stressful environments in the NICU actually have decreased formation of those grooves and folds. So when I teach this topic, I show these images to staff, and it is really impactful when they realize that the NICU environment and what they do can actually change the way that a baby's brain develops. The program also includes in-depth lactation and breastfeeding training for the staff. And I have to say, when I first talked to the staff about this part of the program, they laughed, because to them, breastfeeding is just what they do. It's natural, it's easy. But what they found in the end that it again is one of their favorite parts of the program. And they said they didn't even see breastfeeding problems before, and now they're able to recognize them. So the staff are taught about lactation and breastfeeding, and then they can support and assist these mothers, helping them have a successful breastfeeding experience, which is especially important because formula in Uganda, baby formula, is cost prohibitive for most families. And if mothers don't have a good supply of breast milk and their breast milk supply is inadequate, they will feed their babies diluted tea, sugar water, or maybe watered down cow's milk if they can afford it. Another component of H2H is a program for providing education for mothers and families. Tadeo teaches classes daily on subjects such as danger signs, child development, breastfeeding, feeding, and many others. We want mothers to leave that NICU feeling confident and empowered to take care of their babies when they go home. We also implemented improved discharge processes, ensuring that all the necessary pieces are in place for successful discharge. Follow-up care of these infants is arranged before they leave, bridging that gap between the facility and the community, where so many babies fall into trouble. Our network of community health workers, or VHTs, the one you saw on their new bicycles in the photo above, they're trained in newborn care. They are also equipped with the tools needed to provide basic care and monitoring for these babies. And so the VHTs are embedded throughout the communities in which we work. They use the bicycles to travel to their families' homes. And some of these VHTs pedal sometimes 2 to 3 hours to reach the home of their assigned babies. These are single speed bicycles, and it's over those bumpy dirt roads, and I just find it amazing. They do general assessments of the babies, counting their breathing rate, checking for jaundice. They weigh the babies to monitor for their growth, and they provide education to the families where it's needed. They're trained to refer babies that are sick or need further health. And the most amazing thing about this hard working group is that they're all volunteers. So you won't find a more dedicated group of individuals passionate to make a difference in their community and just help out where they can. If you let us, we could talk all day about H2H, but I'm going to turn it back over to Brooke, and she's going to talk about monitoring and evaluation of the program.
Thanks, Heidi. So we've implemented this program, but what is the point of spending all this money and all of this time and doing all of this work if it doesn't really make a difference in the lives of these babies? So we have a lot of these beautiful moments that you see here. This is a mom with her baby at home, and this is the Corny, the midwife Heidi mentioned in one of our VHTs. But does it really result in the impact we want to see? And as we mentioned earlier, this hadn't really been done before, so we didn't really know what to expect. And as we mentioned, we had a grant from Saving Brains, and as part of that, we needed to evaluate the program. And since this was a pilot project, our evaluation primarily set out to see if hospital to home was feasible and acceptable. So could it be done? Could we pull it off? Could we find the right staff? Did mothers want the program? And did the VHTs and the NICU staff want to give the services? And so we're evaluating this using both quantitative and qualitative research. So the main quantitative indicators that we're looking at is the percentage of babies in the neonatal unit that receive the hospital component of the intervention, and the percentage and number of babies that receive the home component of the intervention. And we set some initial targets for what we were hoping to see. And that was 100% of the babies in the NICU receiving the hospital component and 75% of the discharged babies receiving home visits. And then we initially set some feasibility targets at 70% of mothers that would receive the required education criteria before heading home. And also that 70% of babies would meet the discharge criteria before heading home. These are some of the things that Heidi mentioned. We also set a target of 70% of scheduled visits being completed from the VHTs. And so now we're in the process of analyzing that data to see how we did. The qualitative work is examining if the mothers liked the program, if they thought it was impactful and why. And then also just understanding more about the successes and the challenges that both the moms and the staff, the VHTs, that they all experienced. So we're really getting at the how and the why. And then we're also doing a small pre-post study. We usually want to know the efficacy or the effectiveness or cost effectiveness of a program, but because this was just a pilot and because of the resource limitations, we couldn't do a large randomized control trial. So we selected a small group of babies that did not receive the program, so our pre-group, and a small group of babies that did receive the program, the post. And we made our best guesses as to what change we might see as a result of hospital to home. And there's a fair amount of literature in high resource settings about what outcomes we might expect, but less about the outcomes in low resource settings. As Heidi mentioned, there's not a whole lot of information out there. So we used the information relative to the high resource settings to inform our best guesses, but we are recognizing that we made a lot of adaptations for this particular setting. So we're hoping to see changes in infants' growth, so their length, weight, their middle upper arm circumference, their head circumference, exclusive breastfeeding rates, as Heidi talked about, vaccination coverage, caregiver attachment, and then neurodevelopment, thinking back to those brains. We did assessments of these pre and post groups when the babies were about 6 months old, and we're in the process right now of evaluating those data to see if there was a change in these indicators. And because this study wasn't powered, it's not incredibly robust, but it will give us an idea of impact. And hopefully we will see a trend in the right direction. So once all of those results are back as a group, we look at everything, we look at those results and we see how the pilot did. We talk to experts in the field, we see what they think. And if it looks promising, then we would apply for funding to do a trial so that we would have more robust effectiveness data, which is usually something we'd want to see to more broadly scale a program. And just a note about pilots, there is a term called pilotitis, and this is a phenomenon where the pilot projects tends to go really well. So it's got dedicated staff, budgets, there are these incredible champions, there's a lot of attention on the program, a lot of enthusiasm. And so lots of pilots do go really well, but often the bigger challenge comes when that pilot comes back and the results are good, but it fails to scale more broadly. And another challenge related to this is the complicated funding mechanisms in global health. Just a qualifier that this is not my area of expertise, but I just wanted to mention a few things around this. a lot of the programs that are implemented in country are funded by large multilaterals. So World Bank, IMF, United Nations, or bilaterals, USAID, for example. This is aid from one country to another. And then there's some work funded by foundations. And some groups fund short-term pilot projects, or they'll fund NGOs to implement programs in a particular area in which that country or that multilateral might have a lot of interest, like HIV prevention, for example. And so the work commences, and maybe it's a research study that has huge funding for several years from a large foundation. And often these are run by larger NGOs within the country, and sometimes they might even have international experts that come into the country for a period of time to help manage these. But then when those contracts aren't renewed, or if the program hasn't deeply embedded within that local health system, or doesn't have local champions, these programs often cannot find long-term funding. And so the program ends, and that is kind of this phenomenon of pilotitis. And so we talk a lot about government adoption of programs and why that's so important. But we know that in Uganda, they only spend about $40 per capita on healthcare. The United States spends over $10,000 per capita. Not that we are a glowing example of how healthcare should be done, but Iceland spends $6,500 if we go back to those three different countries with the statistics earlier. So finding funding to implement programs at scale is really difficult. And it's also difficult to integrate a program into an already underfunded health system. So scaling programs is definitely easier said than done. How does one go about it? It's definitely a multifaceted, systematic process. Includes sharing results with the right audiences, publishing papers, talking with advisors, meeting with key stakeholders, getting additional funding, meeting with the groups that would eventually implement programs. In this case, this is just an example of hospital to home. Those groups that might eventually run community health worker programs like this, and also meeting with local leaders who might become champions of that program. And it's not always easy, and it usually takes a huge amount of time. And then ultimately, we think local ownership is really, really critical, especially if you don't want your program to succumb to pilotitis, like we mentioned. So then looping back to the funding mechanisms that usually provide these short-term contracts, this results in a really complicated ongoing challenge. And this is one of the reasons that we think that Adara's funding model is so hopeful, because we think it provides longer-term funding without the strings that can be attached to bilateral multilateral funding at times. And it's also a reason that we believe so strongly in being led by local teams on the ground. And just to mention that our Grand Challenges Canada grant, what GCC is trying to do is develop programs that can be scaled, because they do feel like that is where we're going to have the most impact. So kind of going through this long-term process. So we will wait to see what our hospital to home results tell us. And if the pilot looks promising, then we will hopefully start to walk down this path to growing the program more broadly. So regardless of the outcomes for hospital to home, Adara will remain committed to improving the maternal newborn child health in Uganda, especially for the sick and small babies that we love. And our goal is that we will continue to see more and more moments like this mother and her baby. So that's it. Thank you so much for your time, for your attention. And Heidi and I would be more than happy to take any questions you might have.
Great, thank you, Heidi and Brooke, and well timed. So you've ended just on time, so we like to leave 10 minutes at the end for people to chime in, either using the chat box, or you guys can click over and speak your question. Lee is our colleague in the department who teaches our maternal health course, and she runs an outfit actually quite similar to Adara, an INGO based in the Atlas Mountains of Morocco, together with a colleague of hers, and thinks very holistically about the sort of challenges you guys are describing. And her question, Lee, do you want to unmute yourself and ask your question yourself?
Hi, yeah, thanks for, can you hear me okay?
Yep, perfect.
Can you hear me? Okay. Yeah, great presentation. Thanks for sharing all that great information. I was just wondering what you guys do for prenatal in terms of, do you use the VHTs, or how, do you identify women that are high risk prior to ending up in the NICU?
Heidi, do you want to take that one?
Sure, I'll take that one. Yes, thanks for that great question. It's something we didn't cover in this presentation, but Adara believes in a very holistic, across the continuum type of care. And so, yes, we have a community health program with a safe motherhood clinic that is carried out throughout the villages and communities where the mothers can come for their prenatal care. We also have an antenatal clinic at Chiwoko Hospital where the mothers can come and receive their care there. There's always more work to be done as to increase the number of prenatal appointments. Again, those barriers that I talked about coming to the hospital, just poverty, being able to get to the hospital for those appointments is tough. So we definitely are focusing on how do we improve those screenings, those antenatal appointments, and that care even before that baby is born. Thank you.
So just a little bit more background about the region. That this may interest some folks on the call, but the region is populated by all different sorts of people. Many are Christian, a healthy proportion also are Muslim. Many are settled agriculturalists or live in the nearby small towns or small cities to this hospital that are, sort of 45-minute drive away. But many people in the catchment area are living in, long distances from the hospital in fairly, rudimentary homes and practicing subsistence farming. And the challenges associated with transport in the landscape are really quite significant because for some folks on the northern end of the catchment area, they actually have to take a boat partway to get to the nearest road and then catch a ride from there. So there is quite a bit of not only cultural diversity in the people served by the hospital, but also religious diversity and linguistic diversity as well. So it's a pretty fascinating area in that respect. Other folks want to turn off their mute button and pose questions? Well, Claire, yeah.
Yeah, I was just wondering what sort of resources are available for any of the infants that are born that might need ongoing medical care, either because of a specific medical diagnosis or developmental delay.
Brooke, this is you. You want to talk about this one, your baby?
Sure. Great question. And this is something that we have spent a lot of time talking about and thinking about. So we have actually been working with the London School of Hygiene and Tropical Medicine on one particular program to support children that do have disability. And we know that any child that spends time in a NICU, whether that's in the United States or whether that's in Uganda, some of those babies will go on to have ongoing challenges. And so we knew that these babies were present in the community, but it was really difficult to, one, identify them, and two, provide support to these kids. And we know that there's problems with stigma in addition to the other challenges around poverty that Heidi talked about. But when we created this partnership with London School of Hygiene and Tropical Medicine, they had developed a program that is called ABANA, and it's an acronym, and ABANA means children or child in the local language in Uganda. And this was a program that was developed after a program called Getting to Know CP. And this is a community-based, facilitator-led program that is designed to bring together small groups of mothers that have a child with a disability. And initially they designed the program for older children, which was Getting to Know CP, but they realized that a lot of these kids needed help when they were very, very young. And so now that has been adapted, called the ABANA program. And so this is something that Chiwoko and Adara have started to do for the last couple of years. And we have found that this program, it really is designed to improve the quality of life for these moms and for their children. We know that some of these problems were going to be long lasting, and there's not a whole lot we can do to improve the brain development necessarily, but we know we can improve the bonding, we can improve the way that child is fed, the way they're positioned, the way that we're interacting with them. And as part of that program, the parents also learn to advocate for themselves and to figure out what resources are available within their country or within their communities. And so now some of those moms know how to seek out medical care for this particular condition their child might have, or how to get an assistive device, how to get a standing chair. And we feel that that is a program that we want to see more broadly. And so we're kind of working on finding additional funding to try to scale that a little bit. So stay tuned on that one, but that's a big piece of what we're working on right now. And then Chiwoko also provides ongoing care for some of these children. Adara does have a fund for children that can't afford some of the additional payments that they might, or additional treatments that they might need. So it's something that we continue to think about, continue to talk about, and develop those referral pathways that some of those kids might need if they're not available directly at Chiwoko Hospital. Heidi or Kimber, anything to add there? It's a great question.
I think in terms of medical care, it's difficult. So like I discussed, the health centers that might be located around where they live are not well resourced. So it's a big challenge. If that baby gets sick in the village, it's quite a ways to travel to get to the hospitals. And so that remains a challenge, definitely. And finding specialists as well in our area, being very rural, you would have to travel to the capital city of Kampala to reach those specialists. And often that's out of reach for those babies. I hope that answers your question.
Yeah, so I was just going to add, Heidi and Brooke, that we have a PhD student in our program who's also working on care and early childhood development, and with at-risk or vulnerable babies, some of them, due to substance use disorder or other challenges in the home community that they come from. And so I've told her name's Helen Rossett, and she's on this call, and I've told her a number of times about Abana and the tools that you guys use to screen the little E's and stuff like that. So one of these days we may connect with you on that very topic, but
Yeah, that would be great.
those connections. Is there another question maybe, or, oh, here's one in the chat. This comes from Shauna. Shauna, do you want to say your question, or should I just read it?
I can say it. Thank you. Okay. So I see Uganda is pretty close to Kenya and other countries around. Do you think this problem that you're seeing, is it unique to Uganda? Is there something in where they are, what they're doing that precipitates these kind of problems after pregnancy? Is there something we can do prior to pregnancy? Is there something we can do for mothers in the stages of being girls along the way? Is there something else we can do to prevent it rather than trying to catch up and cure it? Thank you.
Excellent question. Excellent thinking, thought processes. Yes, yeah, there really is. And that's why we want to work across the continuum of age continuum, knowing that even when adolescents, when they're girls, that there are things that we can do and to prevent pregnancy when you're young, because being young and having a baby is a risk for preterm. So yes, all those things. Another one that is preventative in some sense is birth asphyxia, which tends to be a large problem for the population in these low income countries, that because these mothers maybe are not getting the best prenatal care, they wait a long time to come to the hospital to deliver. So they're finishing their work in the field, even though they're in labor. And by the time they reach the hospital, it's really quite late. And often those babies are in distress. And so those babies may be born already asphyxiated. And so that's a large problem of this disabled population right now in Uganda. Just getting those mothers to the antenatal appointments is the challenge. So the way that we got around the problem of families not returning to the hospital, we were going to their home to find them, and finding that is a good way to do that. So yes, exploring the prevention and how do we find these mothers before they deliver a premature or sick or small baby is so important.
I would just also add that, I mean, we know that poverty can also contribute to, having malnutrition during pregnancy. A lot of the moms might be cooking inside with smoke, and there's a lot of complicating factors that might lead a mom to have a premature baby, in addition to the things that Heidi mentioned. So it's tough to tackle all those things. And I think it happens in many countries. A lot of our colleagues work in other regions as well, and everybody's facing similar challenges.
Yeah, which is why maternal health and child health all kind of loop together, because you can't ignore the health of eventual mothers you can't address the health of someone who will eventually become a mother without looking at what's happening in adolescence and childhood in terms of nutrition and development, et cetera. So our colleague Lee, who posed the first question, who teaches our maternal health course, could probably enjoy a cup of tea and a conversation about that with you guys. So I'm just minding the time here, and we do try and break at 10 to the hour so people can get to their next things. So I just want to end by thanking you very much for joining us, and for everyone in the audience for their wonderful questions and their thoughtful ways of considering what's been presented today. I also wanted to bring your attention to our talk in this series next week, which will be presented by a colleague of ours who was connected to us through our external advisory committee on the Global Public Health minor. We have this wonderful external advisory committee. And so we are connected with Dr. Glenn Gielhode of Mission to Heal, and he's going to present a talk entitled "Whatever It Takes to Deliver Global Health Care Education to the Furthest Peoples First." So we can look forward to that next Monday at 2 p.m. Mountain Standard. Thanks, everybody. And again, thank you, Brooke and Heidi.
Yeah, thanks for having us.
Thanks so much.
Thanks, everyone.
Have a great rest of your day.
Bye for now, everyone.
Bye.